Is now starting. All attendees are in listen-only mode.
Welcome, everyone. How you doing tonight, Rich?
I'm doing well, thank you, Guy.
Well, good.
Looks like we got some of the early voters on.
Yeah, I was wondering if we would have a full house tonight with everyone with the elections going on. But thanks, everyone, for taking your time out on this Tuesday evening. I'm Guy Yatros, and
I'm Dr. Rich Drake. We're coming to you live from, I'm in Texas tonight. I'm not sure where Guy is. He's in a hotel lobby somewhere, living out of a suitcase again. But thanks for joining us, Guy.
in North Carolina here tonight, actually. So everything's good. We're going to talk tonight about the treatment steps that you need to successfully treat your patients in dental sleep. And, Rich, you and I do a lot of talking to groups. And typically I start out most groups with a raise of hands. How many of you all are screening all your adult patients for oral cancer? And, everybody raises their hand, right? And then we say, well, keep your hands up. How many of you all found an oral cancer on at least one patient in the last 12 months? Few hands stay up. In the last 6 months, or found 2 in the last 12 months, or 3. The most I have ever found in the last 5, 6, 7 years of doing this, thousands of dentists, is 6 oral cancers in a year. And then you ask the same question about sleep apnea. How many of you screening your adult patients for apnea? And the people who are doing it found somebody yesterday or today, the last time that they screened it, because the cancer incidence is 1 in 1,000, and I think it's closer to 1 in 4 now. Adults has obstructive sleep apnea. Is that accurate, you think, Rich?
I think it depends on what part of the country you're in. We've been accused by Charles Barkley of being a little more round down here in San Antonio. So I think it probably more than 1 in 4, where I live. So, part of that depends on where you live. And, it's what we look like when we fall asleep, and we're on our back and our jaw's falling down. But that's also why we can make a living at this as dentists. So we want to talk about some of the ways we do that.
Yeah, and I think the point being that it's really our job and obligation to do this, and until recently we got some pushback from our dentists that were educated.
Yeah,
and as of a year ago, the ADA says that if we want to do our jobs as dentists, that we are the most well positioned to help identify the patients who are at risk, because we're in the oral cavity. We see the things that we see our patients regularly, we look at their health history, and really as part of our job, we're encouraged to screen our patients for obstructive sleep apnea and sleep disordered breathing. And I think that's something, if the dentist realizes it's their job that they have to do this, that these steps we're going to go through tonight we can make sense of those. But until we as dentists believe this is our job to be looking at this, we'll still have a slow start to our practices. That one change mentally in dental offices and teams can make a substantial difference in how well their dental sleep practice goes forward.
Well, and also how many people we get to treat. It's just like you're talking about, screening, for oral cancer and that kind of stuff. I mean, we got to remember there's a lot of people out there that have this disease, and we're in a great position to do that. So who is this guy?
Well, this is what my point is. It's important. As I go to the gym, and this has been several years ago, back in 2011, this gentleman died, and I used to see him at the gym all the time, and I would say, hey, Doc. He'd say, hey, Dr. Man. I'd say, hey, Chief. He was the fire chief of Manatee County, and a week before he died, he came up to me and said, hey, Doc, I can't wear my CPAP, and I saw a sign on the back of your car talking about treating sleep apnea with dental devices. Can I come in and see you? And I gave him one of my cards, and you know what? He never made it. Here he is, a young, I think he's young because he's in the 50s. He's my age and your age, Rich. All of a sudden, that's young to me. But he went to work out. He won championships in weightlifting and so forth. And then here he is, died in his sleep. And they feel the apnea had something to do with it. I think we failed him as a medical community, and we can do better than that. And that's part of what we're going to talk about tonight, because some of the things we'll talk about maybe are a little controversial about how we can get our patients tested. But I don't think this guy would have cared how he got tested if he could have been tested and treated and still be alive today. So
I don't think his family cares either, Guy. So with that, even though it's election night, we try to be agnostic when it comes to some of the political sides for what you choose and how you do this. But we keep saying keep the patient's interested, at heart, the best interest at heart. And you know, when we look at what the Federal Motor Carrier Safety Administration, when we look at this, you know, these people are managing the commercial drivers out there, and they're really starting to take a hard look at this, aren't they, Guy, and what they're doing and how it's affecting all of us out there on the roads.
Yeah, a year ago they basically said it's the part of the standard that if a driver is sleepy, has a big neck, they have high blood pressure, they snore, that maybe it'd be a good idea to test them for sleep apnea. And you know, I think my point being, if the Federal Motor Carrier Safety Administration is doing this, do we think as dentists, as medical professionals, that we need to be involved in at least the identifying of these patients? And the answer is overwhelmingly yes, because more patients go see us as the dentist than they do as their medical doctors each year. And Rich, you know, I met you, it's probably been 15 years ago now, and I remember you telling me then, you know what, nothing's changing. 9 out of 10 people have this problem, don't know they have it, and we've got to do something to help this. And that's why we kind of came together, and you know, maybe we're making a little bit of headway, but as we're helping, more and more people have this, and 9 out of 10 people have apnea, don't know they have it. And those ones who have it, a lot of them aren't successfully treated, so we can really make a difference in dental offices.
We can, and we should.
You're the
start moving.
Rich,
yeah. So when we look at, you know,
you're
how
the one that brought this to
your attention. Yeah. When we look at how medicine looks at this, you know, and if somebody comes in, you know, most of the patients I talk to, Guy, they say, man, I got to tell my doctor for 5 years that I'm sleepy and I'm tired and I snore before he even thinks about even talking about a sleep test. But if we suspect sleep disordered breathing in somebody and we say, hey, you should go get a sleep test, you know, we're going to, you know, well, up until relatively recent history, we only had PSGs, not the home sleep test, the in-lab test. So how many people do we actually get that show up at that test? You know, or go for the test. Yeah, keep clicking the button. So we're going to refer them, but only about half of them will go. And we're going to confirm a diagnosis in most of those people that go, if we're doing a good job of screening them. And then everybody gets what?
CPAP.
Everybody gets a CPAP, you know. So we give them all a CPAP. How many will go get their CPAP? You know, about half of them. How many will wear it? Oh, you know, about half of them. So, I mean, you know, if we you could argue these numbers a little bit, but you know, if we go to the dental model then, and we were screening for our patients and we suspect that they have a problem, and now we're going to get them to do a home sleep test. And again, there are multiple ways that you can do this. In my practice, I actually support all of the medical doctors, and we do this through the MDs and that, but there are different ways to do it. But we get most people to do a home sleep test. You know, most will do it. And then, you know, if we're screening well and we're doing our risk assessment right, most of those people will have a diagnosis of sleep apnea. And if we make them a dental device, you know, we know that most patients wear their dental device. And even though we're not quite as effective as CPAP, depending on how bad your severity is, at the end of the day, you know, when we talk about mean disease alleviation, we're simply treating, I think, for the most part, more of the apnea that's going on out there. So, you know, Guy, if we cut our numbers in half and we double their numbers, we're still pretty good at what we do. So, you know, we've got to start to look at this a little bit differently as dentists. You know, our patients, they're walking through our doors. 9 out of 10 that have this problem don't know it. So we got to figure out a way to get them in the funnel.
Yeah, if the fire chief would have had his dentist doing that years before, maybe he would still be around today. So we are going to get into the treatment steps, but we just want to set the stage for how important this is to do in your practice. If you want CE for this, you will get an email within 72 hours to get CE for attending live tonight. If you want to watch recordings, we have that later. If you don't get the CE, check your spam folder because we will send it out. This is Rich and I. We already introduced ourselves. We've been doing this for nearly 20 years independently. So we've done thousands of devices, helped thousands of dentists do this in their practices. That's what we do every day, all day long. We have our webinars going forward for the next 3 or 4 months, and then we'll be meeting around the holidays, December 11th. So again, on a Tuesday night, we're going to talk about getting your medical referrals. I talked to you this morning, and you said, gosh, you're doing a lot of devices, and most of them are still coming from medical referrals, correct?
We did 87 in the month of October.
Wow.
So yeah, that's a lot. And at least 90% of those come from a medical referral. So, you have to play with the physicians here. We're certainly not promoting that you do this, you become an island and you do this on your own. So I'm really looking forward to that one, Guy, because I really think that tonight's good because we got to know how this happens. We got to understand the treatment steps. So I'm really looking forward to, what we have to say, because I think this is a real challenge for most dentists in how they can reach out and, start to grow their practice and get these referrals. And that's what I'm going to be talking about at the symposium as well. How to get your practice from 0 to 60, in 2.4 seconds, like some cars can do out there. But it takes a little bit longer than that. It takes a lot of work. But we have a stellar lineup of speakers. What a better place than Florida in February, right, Guy? Fantastic. We've done this for a couple years now, and it's going to sell out again. So
it's going to sell out, and the rooms are $250 a night while they last, and they're really going fast. So on the beach there, we have a great lineup of speakers. It'll be well worth your time, I promise. So we're going to talk about the steps now tonight. And by the way, if you have questions, keep putting them in the question box. We have our team of dental sleep medicine experts answering those as we go along. And Rich and I will get to any ones that they don't at the end. So just keep those going along. And if you ever want any more help, you can also type in consult, and we'll meet with you and really evaluate your dental sleep practice too. And we'll go over that at the end. So the steps of this, if we look at them granularly, which we'll get into in a moment, there's individual steps, but at a high level, in order to succeed at dental sleep, you just have to have a system and team members who are responsible for screening, testing, treating, and billing your patients. If you have those systems and team members who are responsible for doing this and the steps outlined that we're going to go through, you'll see as many patients as you care to, because again, 1 in 5, 1 in 4 adults has this problem. So unless you're living in an area that we're not aware of in the United States, you're going to have as many of these patients as you want. And, Rich, when I first met you, I think one of the things you really helped me with was I was trying to fit this into my busy practice. You were doing just dental sleep, and I was running a fairly busy restorative practice. And I'm like, man, I'm spending so much time doing this because I'd go into the consult and I wasn't prepared, and I would talk to the patients. And, I think I got to where I was doing it fairly good, but I wasn't efficient. And I think through what you taught me and my real need to understand a way to do this efficiently, we've got a system now to where with under an hour of time, of the doctor's time, you can go through each of the steps of screening, testing, consult, impressions, device deliver, follow-up, testing, and evaluation on an ongoing basis. And that can be done in about 45 minutes or less of doctor time. Maybe not the first case you do, but if you use systems we're going to outline for you, DS3 can really make you efficient at doing this. And I think the day that I met you, because I don't know that I would have incorporated it in my practice had we not been able to put these systems together, because it was just too arduous before.
And I know some of you out there are thinking, no, but I think we talk too much as dentists, Guy, in general, but you're right. You're absolutely right. I mean, I love that slide and the way you put that thing together, because there are just some moving parts. And I think if you're getting started in this, you got to figure out how to get your arms around the whole process. And that's kind of what we want to talk about tonight. We don't want to talk about which device to use when a patient's jaw hurts or, what you do. We're not talking about that tonight. I want you to get your arms around this and understand. Go back one slide real quickly, Guy. So when you look at those steps, that's what we're going to talk about tonight. That's the chain that Guy has there on the next slide. And if you don't have a way to go from one of those to the next, that there's some moving parts there, or those are the gears, whatever you had that slide, Guy, then the thing starts to kind of break down. So you gotta have a system for how you do this and be smart, and you can be efficient and do it in not much time. And
I mentioned that each one of these steps isn't a big deal. We'll make a system for you to do each one of these. When you look at it, try to jump from screening to finish, yeah, it's a big step. But if you have the little baby steps in between, all this will be great. If you have any of those steps missing, it becomes more challenging. It becomes more arduous, and it becomes more likely that you as a dentist and dental team members will decide not to go forward and do that.
Yeah. Just throw your hands up and say, man, I just can't get paid. How many times we heard a dentist say that? Well, how many cases have you done? 3?
Okay. I can't get patients to say yes to sleep testing. I can't get this. And each one of those steps requires something that you've just got to keep in mind, that nothing you can do as a dentist is more needed. I mean, we're past the days of rampant decay in most areas of the United States, and with fluoride and all the preventative care that we have rampant obstructive sleep apnea. 1 in 5 adults has this problem, maybe 1 in 4. Millions of patients have this and are untreated. It's the most serious undiagnosed, untreated medical disorder in our country. And if you believe that part of the protocols in my office, it's my job to screen these patients and let them know that they're at risk for all these bad things, and to help facilitate getting them tested, you have to have systems. You got to be prepared to do that, and that's what will help you do. Be prepared. You will have as many patients as you need, and Rich and I are going to help you with the latter part here, this prepared part. I tell you the truth of the matter. That the slide before, this one's more important. If you believe it's my job, and I let the patient go home and they say, I don't want to be tested, I don't want to go down to Dr. Smith's, I don't want to do a home test, I don't want to do an in-lab test, whatever you're going to do, and you let them go home and they end up being like the fire chief, and dying because you didn't do your job, that's the hard part. It's going to affect you.
I promise it will affect you.
And hopefully. Then you'll believe. So we'll help you be prepared. We'll try to motivate you to believe. The ADA says you should believe now. So this is not something that's, something you should casually do. We should all be doing this. It's not just needles in the haystack. There's just so many, it's like hay in the haystack. And if you don't believe me, I think the one thing we always talk about is a low-lying fruit here. The low-lying fruit, if you'll just go back and ask your patients, have you been diagnosed with apnea? And if so, are you wearing a CPAP every night, all night long? And you're going to have a bunch of people in your basket.
You will be amazed. I'm telling you, if you just do that tomorrow, most of you will find 1 or 2 patients tomorrow. Just tomorrow, walking through your door.
You already know they have apnea. And that's the 10% that know. So you figure out there's 9 more out there of those patients who don't know. And that's the low-hanging fruit. So, how are we going to do this? You have to. I mean, I think, Rich, we used to say you should screen your patients. I think I'm changing the way I say this to, it is our job as dentists to screen. You're better off to do this than pick up the periodontal probe and look at their teeth, because this is more prevalent, more devastating. And until we believe it's part of our job, it's not going to get done. So I don't think you should screen. It's that we have to. And you can make money doing this. I mean, that's, if you're not, you're losing money. But hopefully that's not the motivating factor. There's a lot of way to identify the patients. I mean, within your practice, Rich, you put those posters up in your practices and practices we've consulted with, and letters to our patients and things like that.
Yeah, there's a lot of ways to do. I mean, like you said, Guy just asked questions. You just said, hey, have you ever had a sleep study and been diagnosed with sleep apnea? If that's all you did, you would probably help 100 or 200 patients in the next year. You make dental devices on those people. So again, those are people that are already diagnosed. So we've got to find a way to identify these at-risk patients. So, one thing that every single dental office I've ever been in, Guy, and we've been in a lot of them now, is very good at doing medical histories. We were just grilled into, most of us in dental school. So these are the red flags. Somebody see, are you taking any new medications, Guy? Oh yeah, my doc put me on blood pressure pills finally. Because now I'm dealing with my AFib too. I mean, those are red flags. Every time you hear everything that's on here, something should go off in your head and say, hey, this guy's at risk for having that, so we need to have a discussion about it.
Yeah, and I think that if you want to take a camera out and take a picture of this real quick, email us and we'll send you this slide. If you learn nothing else from this, if you'll memorize this slide, I printed these out when we first started doing sleep apnea in my office, and these things should just jump out at you. Someone's obese, someone has diabetes, it should jump at you that, hey, they're at risk. And you really need to understand why they're at risk, and we don't have time to go into that in detail, but you should really believe that when I see someone who has AFib, that 50-50 shot that they have apnea. So if understanding as a background is mandatory for whoever's going to be talking to these patients. Now, we need a quicker way than just saying, hey, I got to have this in the back of my mind and always be remembering it when the hygiene patient's late and we can't find the implant part and all the other things that happen. So we need simple steps for this. And I think a lot of people try to jump to, the patient comes in, they got a neck and they say they snore and they want to show them a dental device and say, let me show you how to fix your apnea that you don't know you have. And I think that's where people get really ahead of themselves. So if we slow down a bit and we set up a system to quickly identify these patients and know who's at risk and who isn't, or who's at more at risk, we should say, because everybody's at risk because we all have collapsible airways. And then we have a way of communicating that with the patient to the point where they acknowledge that they're at risk. And then we need a quick way to, or at least a predictable way to test them, and then we can treat them. I know in between there, sometimes we probably need to talk about money, which we can get to as well. So, Rich, I know we used other screeners, what, Stop Bang, Berlin, Epworth, before we digitized the things for DS3. Those all work, but I really, we get such positive feedback for the way we do it with DS3 with these cloud application that we have.
Yeah, there's something about that computer screen or that tablet screen, you know. I mean, and when we do this, we're not doing anything, you know, that's rocket science with this. We're asking the same kind of questions and we're doing the same types of things that other people are doing. But when that thing says, you know, I'm at severe risk, well, I'm at severe risk for what?
Right.
You know, that's the point.
Yeah, sorry, I didn't mean to interrupt you. A little bit of a lag here, but yeah, they're at risk, and you know, they just answer some questions on the tablet screener, and when they're holding that in their hand, I think what they do is they ask a question that we want to answer, and that's one of the best communication skills you can ever master in life and as a dentist. Is if you want to tell a patient they need a crown, how about if they ask you, "What am I going to do about my broken tooth?"
You think I need a crown on that, Dr. Yatros? Yeah,
wouldn't that be nice? Well, we can do that in dentistry, and you can do that here. They're looking at the severe risk, and they say, what am I at risk for? And now someone needs to step into the picture to discuss it with them. And that's, you know, we can do a whole webinar on screening, but you have to have a system where it quickly identifies who's at risk. And then you have to have a team member or members in your office who could come in who passionately believe that this is important, and that can go through into the conversation. The patient will acknowledge that, oh my gosh, I don't want to die in my sleep. I don't want to have a stroke. I don't want to be impotent. I don't want to have diabetes. And they will agree to have the sleep test. And I know we make that sound a little easy, but if you believe in it and you have those systems in place, it really is fairly easy. That first part being the most important. So at the end of the day, the patient says, yeah, I understand. I'd like to see if I'm going to quit breathing in my sleep at night. And so now they're ready to have a diagnosis, and then you can move on to the next step, which is to get them tested. And you better have a plan here too, right? I see the ball get dropped at times here.
Hey, Guy, what do you know, you should probably get a sleep study done. I'll see you in 6 months. We'll clean your teeth again.
Yeah.
Did I create
any?
Yeah. Did I create any sense of urgency in you? So that's where the plan is. You know, the plan. Guy, would you prefer an in-lab test or a home sleep test?
Right. Yeah, we need to have you tested. That's what the doctors say, right?
Yeah, and they don't. You know, if you saw a big thing growing on the side of their tongue or something like that looked nasty, you wouldn't go, "Hey, what do you think about biopsying that?" You'd go, "No, you get that thing biopsied, man. That looks terrible." So you have to learn. I think what you said earlier, Guy, really resonates with me a lot. That you have to believe in it, and you said that a couple of times now. You actually talked about your staff. So you got to have your staff who believes in this and they do this. So you have to believe that what you're doing is worthwhile. But now, you know, now we want to get these people tested. So have a plan for how you're going to do that.
Yeah,
what
and
we
still have people. Yeah, we still have people go into the sleep lab, and for many years, actually, one of the original conversations when Rich and I were beginning dental sleep solutions in DS3 was the biggest challenge. Only way we had to get them tested was they had to go spend the night in the sleep lab, and what we found is a lot of people just won't do it. Even when physicians recommend it, it just raised the barrier to getting them tested to be more difficult. Now, we still do this, and we still have an option. And I suggest that you meet with your local physicians and that you meet with your sleep labs and you talk about how the referrals to them will work. And a lot of them will also do home sleep tests. And we still do this, but far and away, most people would prefer to have this done at home. And furthermore, a lot of times it's not even anybody's call but the insurance company. And insurance companies are becoming to where they will only pay for home sleep tests. And, you know, it really is becoming the more preferred way to get patients tested. And when you just asked me that question, Rich, when you ask patients, hey, do you want to go to the sleep lab or do you want to get tested at home? What do you get 99 out of 100 times, right? I'd rather do it at my house.
Absolutely.
Yeah.
And then,
Yeah.
of course, the next question is, well, which one does my insurance pay for? Because
Right.
maybe that might change my mind. But the reality is almost all the payers now are doing home sleep testing. You know, it's a lot harder to get a PSG or a polysomnogram. That's the in-lab test. I know we throw around a lot of acronyms. If you're new in this, we apologize. But, you know, PSG is the in-lab, home sleep test is that. So I don't particularly care, Guy. I just want you to get sleep tested. You are at high risk for having a disease that can kill you. You know, we need to get you tested. Who's your doctor? Who can I call? How can we do this? You know, so we have different ways of doing this. So again, I like the way you put that, Guy. A PSG, you know, they hook up all these things and we're measuring all this stuff. It's certainly a more accurate test, but I think it is absolutely a less normal night's sleep than in your own bed with just a couple of things hooked up. I mean, neither one's great or neither one's perfect, but you know, in the end, the home sleep test is good enough. You know, we don't have to worry about that 99.9% of the time.
Yeah, and here's where, you know, it becomes a little bit cloudy. So if we want to utilize a home sleep test, the way that we certainly can do is, I'll jump down to the item number 3 here, is we can work with physicians like a primary care or a sleep physician, maybe a sleep lab who dispenses home sleep tests. I have one that's less than a mile from my office, and oftentimes when patients, depending on insurance and so forth, they need to have a home sleep test, I refer them to him. He's a neurologist who's board certified in sleep. He meets with the patient, he orders the test, he reads the test, he sends a diagnosis back to me. We have a protocol, though, that we agree on. I don't want to just send it to him and the patient goes to oblivion and I never see him again. We have a protocol for follow-up on my office, his office, who gets recommended a CPAP, who gets dental devices, and we try to go by the AASM, ADSM standard. So that way works great. If you can have that physician in place. I know that some dentists struggle with that because they don't initially have an office, a physician rather they can refer to. What's a little cloudy at times is can a dentist have their own home sleep test and hand it to a patient and have that patient bring it back and then somehow get that data to a board certified sleep physician and let them read the raw data and sleep technologists interpret it and make a diagnosis. There's also companies that you can order from a dentist, can order these home sleep tests, and the test can go to the patient pays the company directly. They have board certified sleep physicians who read those tests and come back with a diagnosis. Those are the 3 ways that we know of that can be utilized, and the third one takes a little more effort, but no one can really give any negative comments on. The first 2 really depend on your state dental board, whether that's recognized okay. And in most cases, there's no limitations in most states, and that's a moving target that probably would be best for another discussion of probably another 30, 40 minutes in and of its own. But there really is not a reason why between PSGs, 3 ways to get home sleep tests, that patients who are at risk don't get a test somehow. I mean, it's so much easier than it used to be.
Well said, Guy. That's the part, you know, and in DS3, we have ways you just click a button and you can do that. And, you know, the home sleep testing company will contact the patient. They'll verify the benefits. You know, I like, you know, I don't want to mess with the home sleep testing myself, Guy, that much. You know, I want, hey, that's somebody else, that's their area of expertise. I just want you to have a sleep test. You know, let's figure out the best way to do that. So, and you got to have a system for managing all this stuff. My gosh, you know, there just aren't, you know, the current dental softwares that are out there, it's like trying to put a square peg into a round hole. You know, they just don't work that way. That's why Guy and I developed what we do. And sure, a little bit of this is a sales pitch for us, but it's true. I mean, we help dentists do this. We help them be more successful because you got to have a place to put all this stuff. And if you don't, it makes it a lot more challenging.
I mean, you look at everything on the screen, there's really not a place to put that in. Dentrix, EagleSoft, PracticeWorks, whatever dental software you're using. They're great dental softwares, but they're not great dental sleep software. So you're either going to have to come up with a system on your own, making spreadsheets or paper forms or what have you, or you're going to have to look at something like DS3 to help manage this if you want to do this in the under hour time that we've talked about and be efficient in doing it. So again, I think Rich disclosed that maybe it is self-serving, but we honestly believe it. We wouldn't have built DS3 if we didn't feel it was necessary. We didn't recreate the wheel. There was no wheel, and we created what was necessary to make this efficient. So if you want to know more about that, by all means, type in consultation. We can certainly tell you how we can help you with that. But, you know, one thing that DS3 does well is it helps me track success for dental sleep patients. And you know, when I do lectures, Rich, I always say, well, why would anybody put a CPAP on their mouth at night or their nose or put a dental device in? What are we trying to accomplish? And the reason a lot of dentists have struggle is because they don't set the goals of treatment at the beginning. And these goals are seldom the same. There's really two categories of why would anybody strap a CPAP on? Or why would anybody put a dental device in? Well, there's really two goals, 3 steps, I should say. I think I put the wrong slide in. I meant just to have these last 2, and of course they need to wear it. But the 2 goals are really that they have their symptoms improved and that the number of events an hour are reduced, so the apnea load, so to speak, is reduced so that they're at a healthier place in life, so they're not as at risk for all the negative health ramifications. And I think defining that at the beginning of treatment really makes a big difference, because in some cases people just want to quit snoring and that's it. Other cases they had a stroke and they just want their AHI lowered, their oxygen levels better. They want to be at less risk for future problems. Sorry, I rambled a bit there, Rich.
No, that's good. You know, I always try to get 3 chief complaints out of every patient guy when I do a consultation. I say, okay, I got my magic wand here. I wave it. I can fix one thing related to your sleep. What would it be? Oh, definitely snoring. You know, my wife, she kicks me out of bed. I want to sleep with same bed with my wife. You know, I want to do this, that. Okay, what would number 2 be? And as a dentist, you need to learn to be comfortable with silence. You need to occasionally just stop talking. And I usually, you know, I'm kind of tired during the day. You know, I this, that. So, but again, a lot of this comes back to we set these goals for what that is. And then I talk about, you know, what can we do for your snoring? What can we do for your daytime sleepiness? And give them realistic goals. But again, we're laying the foundation here, and we're getting ready to put the slab on, you know, for the house. But we can't do that if we don't have a really good foundation. That's maybe another way of looking at it.
Yeah, have to have a plan. You have the architect draws out the plans, and I like your 1, 2, 3. We know that that's what we're trying to accomplish, and it's going to be different for every patient. So again, if you want to know more about DS3, just type in consultation, and we will sit down. We'll actually just help you look at your dental sleep practice. We'll see where you are, where you want to go, and how we might be able to help you, give you some great free advice. So anybody that is interested in that, just type in consult, and one of our trainers will meet with you at no cost. I think it'll be well worth your time, just to help you with any challenges that you have beyond here. So we're going to go through each of the appointments now: the consult, exam, device delivery, 3-week evaluation. We'll look at symptoms and how we've improved those, and then we'll look at the sleep tests and how we've improved what's the AHI, the SpO2 readings. Then we'll talk about 6 months. So, you know, these are the steps. The consultation. I think that if you have these 3 things in order before you walk in the door, I mean, this happens really before the patient even comes in. They've got a diagnosis. We know they have apnea, but how do we know, you know, what we're going to treat them for? Well, if they come in and we have a copy of their sleep study, and we know what their symptoms are, what those things are. Now, we're going to still ask them the question like you did, Rich, but we've got a really head start on everything, and we know how much it's going to cost the patient, or at least an idea of how much it's going to cost. We can have a consultation that's very productive, won't take a ton of our time, and at the end of the day, we can make a treatment decision. If you're missing any of these 3 things, you can't finish the consultation. I mean, you're going to have to call them or come back. We need this information to really have a successful consultation. Rich, do we have some discussions over what we were going to dissect the sleep test out of? So we had some when we looked at these tests. When we started,
it was the list was that long, right? And what we found over the years, you know, was people just don't. But again, this is kind of like that placeholder. You know, you got to have a place to put this information, and we're, you know, that our system does this very well. So, you know, what kind of test it is, and was it a home sleep test or in lab? You know, how old is it? What was the diagnosis? Was it mild, moderate, severe? And then we look at AHI and RDI, and is it worse on their back? And the, how low their oxygen goes and how long they spend below 90. So we think this is kind of the minimum for what you have to have. I don't think you need sleep staging in there, and you need a lot of these other things in there that you can get from certain types of sleep tests. But we think at a minimum, you should at least try to get this information.
And again, this is done before the patient comes in. So if you use DS3 and you order tests through DS3, this is done for you. If not, someone on your team needs to be able to look at this test, and if it's 2, 3, 5, 8 pages long, extract the information that we have out here. So at a glance, I can see this patient has almost 30 events an hour, which puts them at the severe category, and their oxygen's dropping way the heck down, so that we can really know without having to flip through all those pages while the patient's sitting there in the chair and we're scratching our heads. The same thing with the symptoms. If we know before they come in what their complaints are, what they've tried before, and what their health history is, we've got a really running head start on this. Rich, when I do courses a lot, I'll pick on someone in the audience, and I'll say, "How you doing today?" And they almost always say, "Fine." To try to get these symptoms out of somebody, but just by talking about it is fairly difficult. It's difficult, but
it's very time consuming. So
especially if they're not doing fine. Because then they're gonna you either have fine or you have a lot of information that you maybe don't want.
Well put.
Go ahead.
Yeah. So, but again, you got to ask, and if you have all of this stuff beforehand, I do these I'm doing 5 to 10 consults a day, and I go in, I get to the office an hour early, and I go through all 10 of these, and I make my own progress note, and I cut and paste, everything that's there. So when the patient sits down, I say, "Hey, guy, I'm so glad, Dr. Greenspan referred you over here. I have a sleep study from this time. You talked about these being your problems and this and this and this." And people just kind of look at me and go, wow, I guess you really do. I guess you really did read all that stuff that I put in there. And I say, "Yeah, I do, and thank you so much for doing that." But like you said, I think that goes back to, Guy, your slide where you had the treatment steps, and you were talking about, we could do this in and under an hour of the dentist's time. I know some of you are thinking, man, you must be doing a crummy job. I challenge you. It costs you money to come to my office, but when you come to my office, you'll go, wow, that they are doing that this way, and that's what we're doing. But having all of this stuff in there, and that's why, nobody else has this type of detailed sleep questionnaire that gives us a little bit of that stuff that you're talking about, you're getting out of patients, and it is very important.
Yeah, at the end of the day, we still ask them those 3 questions, but we say it differently. Go, "I've read through this list. I see these are your concerns. I understand who your doctors are." And they're blown away and say, "So out of all this, what's 1, 2, and 3?" And that conversation takes just a few minutes, as opposed to if you didn't have all this to start with, you'd be in there for over an hour. And we have a great place to track that in DS3. You can just see at a glance what their Epworth is, snoring levels, energy levels, sleep quality. And as you can see, as we go to treat the patients, we'll follow this up with further columns, so at a glance we can see how well they're doing. We have what's called an instant eligibility check. With over 4,500 billers, we can know instantly if they have coverage for the dental device, if so, what their in and out of network deductibles are, how much has been met, how much their co-pays are. And we don't always know the billable, the allowable amount, but we can take that information with a click of a button, and we can extrapolate what I call the MOOP, which is the maximum out of pocket for my patient. So that's what they want to know. What's the worst case scenario this is going to cost me? And I have that information at hand, ready to go. So now we can have a consultation. I'm not going to spend a lot of time on this slide because there's a lot of information, but basically we want to go through all this information. You know what I hate more than anything, Rich, is for someone to fill out at a doctor's office, ask me a bunch of information, and then I walk in and they go, "What are you here for?" And they start asking me the same questions over and over again. And you've already filled it out. Then you tell the assistant, then the doctor asks you the questions. All this information's there for you. You can go through it. You can basically tell them what I know about the patient, tell them what your options are, go through treatment concerns, and this can be a fairly quick process if you are prepared and you have some team members doing some of the work ahead of time. Team members will do 20 minutes or so ahead of time. I'll come in and do about 10 minutes on a consult. The whole thing usually takes about 30 minutes. I think we schedule 40 because you always have the occasional long-winded individual. And that's the way you can do as many as you're doing each month, because we're prepared and ready to do these things. So
So we're walking through the steps here, aren't we, Guy? We've
yep.
identified people from screening. We've got them sleep tested. They're diagnosed. Now we're sitting down doing a consultation. We're going through all the questionnaire. What are the goals of treatment? We're looking at that. Are they a candidate for this? So a lot of you will get hung up on the exam part. And this is, you don't have to make this real complicated. When we look at this, again, we put nice big pictures in there, so you look at malum patti, you look at tonsils, and you have your staff walking through this while you're doing that. Hey, the maxilla, oh, it's very narrow and it's kind of high. The mandible, it's just how we do this. They just walk through it. We're clicking boxes and we're doing all this stuff. So again, it doesn't take a whole lot of time to do this type of thing, but you got to have placeholders. You got to have a way to do it.
Right. And, probably one of the more important parts is looking at the muscles and then the joint, and then certainly how far the jaw moves forward and backwards. There's a lot of different gauges that are available now. George gauge was the only one around until the patent ran out a few years ago. I think Pro Gauge is a great one made by Airway Management. I'd probably say it's a good one to buy if you're looking at getting into this. There's all kinds of videos, including our own on YouTube. So we're not going to spend the time to tell you how to use this, but we're going to use it to determine the range of motion. And then we're going to start them at a certain vertical at a forward comfortable position. Understanding we start back conservatively typically because we can always go more forward. If you go too far forward too quickly, you're going to get in trouble. So the devices are forward but comfortable. And again, you can look at videos on how to take those bites. There's no rocket surgery involved in those. It's fairly simple. We have some tricks that if you look at our YouTube page on that, or if you want to type in consultation, we could certainly go through that with you. But it takes we decide which device we're going to do. We have a whole webinar on which devices, and to give you the take-home message on that. What do you say, Rich, about devices you can't make? I forgot how you say it. What is it? A bad one or something?
Yeah, I teach you can't make a wrong one, but you can make a better one, Right. So again, we could talk for 3 or 4 hours about that, but at this point, we're not here to talk about that. But I do think from your exam, and as you get experience in doing this, you'll get better at which device seems to work a little bit better for which particular patient. And I think most of us are good at this as dentists, Guy. We're good at making things fit. It's no different than anything else. It's too tight. It's right here. You just got to make it tight, good and fits well and comfortable. And it's not poking or pinching anywhere.
Yeah, and I think the couple key take homes on the device delivery. Before we ever put it in their mouth, I say, you know what, you're going to tell me this is too tight. Almost all patients feel it's too tight to start with, and I want to set that expectation so they don't have me start adjusting it. We make them a repositioner to help us get their jaw to go back in the morning, and then we go through the 3 steps of treatment. The only thing I care about is that you wear this every night, all night long. If you can't wear it for any reason, you let me know. If it's sore or something, that's expected, but if it's so sore you can't wear it, you come in. And if not, I'm going to see you in 2 or 3 weeks. Usually 3 weeks is what I do, and we're going to evaluate it. And then we're going to look at your symptoms, and we're going to adjust the device based on symptoms, and then we're going to look at some more objective data with a sleep test. And we talk about that at the delivery so they know what the expectation is. This doesn't have to solve their snoring the first night they wear it. Sometimes it does, but if it doesn't, the goal is just to get them to wear the device. So they've got the device. They're coming in for their first evaluation. What are you doing these days, Rich? 3 weeks too, or in that neighborhood?
Yeah, 3 to 4 weeks. I used to do a week, and then one of the things I learned from you, Guy, was, well, you want to hear about, the problems they're having, get them in a week. But if you just tell them and you expect them, I think that's part of what makes some of us more successful is we give patients very realistic expectations. You might not be able to wear it through the night the first night, might be a little uncomfortable or this or that. But, yeah, you're wearing it. And if you say no, why? Why are you not wearing it? What kind of problems are you having? Most of the problems I tell you in my office, Guy, it's too tight or it's too loose. Yep. That's still probably the biggest challenge we have, just day in and day out. The rest of that stuff is pretty easy to fix. It hurts this tooth right here, or it does this. I mean, we could talk for 3 hours again about side effects, but we got to get people wearing it, because if they won't wear it, we're not treating them. So this is just step one.
And I think most dentists can figure this out. If you've made partials, bite guards, dentures, fit crowns. You can figure out why this thing's bothering them and adjust it. I have a fairly new associate in my practice, and I really didn't have to give him much guidance on this. He could go in and figure out why this patient's got something bothering him and go in and relieve the acrylics. So that's really, and for the most part, we don't have to do that. Most people do wear it every night, all night long until the next time I see them. I mean, we don't, I would say the vast majority of them do. So when they say yes, we want to say, hey, is it working? And before we had systems like DS3, I would just walk in and go, hey, how you doing? Fine. Is this doing okay? I guess. We really wouldn't know where to go from there. I mean, well, how's your snoring? I think it's better. So what we've done is we have a little bit better, I would say we have objectified the subjective process of evaluating the device. And we also have objective with the follow-up sleep test. But so how do we do that? If they say it's not working as well as we hope by this process we'll define here, then we're going to move the device more forward, maybe a 1/4 millimeter, maybe a 1/2 millimeter more forward every week, and the patient will do that. And then we're going to ask them again how it's working at a period of time down the road. I'll tell you something different here, Rich, that I started doing, saved me a lot of time. I used to have them come back in to say, is it working? This can be readily done with a phone call. And in most cases, you don't have to have the patient drive across town, park, sit in the reception room, take up a chair in their office just to say, have your snoring gotten better? You can do this process by the phone. And then once that's where we want, then we're going to do follow-up sleep tests. So we'll walk you through this. Here's the information we collected on the consultation from sleepiness to snoring. And we just ask them those questions again. And we either have the patient fill out a form and we type this in, or we ask them verbally. What do you do in your office with this, Rich? You just give them you type it in while they're there, or have them do it ahead of time?
I got 2 versions of DS3 running. I have the subjective test and I have my progress note, and I'm going, are you wearing it? Yep. Every night? Yep. Great. Get my caliper out and we measure it, or we count the turns or whatever, so we document that. You're snoring, better, same, worse, you're that. So I don't get into the numbers. I just use better, same, worse in these particular scenarios, but I'm doing that and my progress note at the same time, so that, again, this is an imperfect system. If you guys haven't figured this out yet, with CPAP, we get to put CPAP on, and then we go to the lab, and then we get to titrate all the different settings of CPAP, and we get to figure out which one works the best. Well, we don't get to do that with a dental device.
Yeah. So it goes the opposite. They start with objective.
Absolutely, success. We're starting from the complete other end, aren't we?
We go with objective success. Hope you feel better. Hope you wear it. And I'm telling you, one of the reasons I think dental devices work better is because we start with compliance. We don't even ask these questions if they're not wearing it. So compliance, check mark. Okay, now let's talk about your symptoms. And whatever their chief complaints, 1, 2, or 3 that Rich identified at the consult, we have them answer these same questions before snoring. And at a glance, I can see, hey, their snoring's better, their energy level's better. And then we say, have we reached your subjective goals? And if they say yes, you know what? They're going to keep wearing this, because if that was what motivated them. Now we're going to do objective success afterwards. And again, CPAP goes exactly the opposite way. They start with the objective. And so now I'll back up one slide again. I mean, sometimes we'll have 2 or 3 columns here where we'll ask these questions again. And this data is important because it also goes in our letters, which we're going to talk about in just a second. So, after we go through this, most of the time we will get to a point where the patient says, yeah, you've achieved my subjective goals. I mean, it usually happens. Not always, but the majority of the time it does. And then sleep testing, we can do it with lab or at home. And the way I'd prefer to do it at home, Rich, is 1, 2, or 3 nights. I mean, we do a lot of 2 nights, but we have a pulse oximeter now that do multiple nights. And if we can have them come back and do 2 or 3 positions, like we're showing here, like this might be the position they are after they've adjusted and their symptoms are better. We have them wear either a pulse oximeter or a home sleep test of some sort, and then we have them wear it the next night a little more forward, and the next night a little more forward, and then we have them back it up to where they were comfortably wearing it with their symptoms alleviated, and then we just have to analyze the data, and at a glance we can see that their numbers went down or sideways, and we have to make a decision. We got to use our brains to decide, where would we want to stop them at, but we at least have all the data to make the decision. That's one of the things I really like about the multi-night pulse oximeters and HSTs.
Me too.
Okay.
You said that well.
All right, so we're getting towards the end of the treatment steps, and we've got a few other things to go over, like communication. But We need to see our patients every year to see if they're wearing the device, if they're having any jaw problems, if the device is holding up well, because apnea gets worse with time. It gets worse, 20% every 5 years, something like that.
Well, now we got Thanksgiving and Christmas coming up. We're all going to put on 5 more pounds and all that other stuff. And everybody's got green snot syndrome, and we get sick and our nose gets clogged up, and, allergies and all that other kind of stuff. So the point that I think you're trying to make, Guy, is this is not just a one and done. We have to follow these patients, and we have to help manage this, and we have to communicate with the physicians, because they want to know what's going on. If you refer me a patient, I want to know. But we've walked you through most of the steps here for how we do this. And, one of the last things we certainly want to talk about is how you communicate with your MDs. I know that's our next webinar as part of that, Guy, is, how we do this. But, you just wouldn't believe how many letters we write and come out of my office. I mean, we don't do a letter for every single office visit. But if I get a referral, I certainly want to let that doctor know that, hey, Guy came in. We'd had a great consultation. I think he's a great candidate. His out-of-pocket was a little bit high. He wanted to talk to his wife about it. We'll follow up with him appropriately and let you know what he does. That's how short and simple my letters are. They just let people know.
Yeah, I mean, this is part marketing. We'll talk about next webinar, but this is also your job. I mean, how would you feel if you sent someone to your periodontist, orthodontist, oral surgeon, and they never sent a letter? I mean, would you want to work with them? That's our job to communicate this. So we talked about the treatment steps. Well, this is a treatment step that needs to happen, even if the patient seems to be happy and everything. Because if you don't do this, you're not doing your job. The medical community is going to look at us like these treatments don't work because they're not going to have any of the information that they need. And this is where DS3 really shines, because we can do this through cloud-based faxes. You don't even have to print things out, and it grabs a lot of the data that we've been going over, so it just makes this process easier. We, on average, will do 2 to 3 letters minimal per completed treatment, and those will go out to usually all the physicians, which there's 2 or 3 or 5 of them. So you're doing 12 letters or so per case, and that's what needs to be done legally, but also it helps with marketing. DS3 just makes this process so much easier. You can make custom letters. We give you letters. It's one thing that I would say that a dental sleep medicine practice software can really shine doing. Last thing is we need to get paid for this, and medical insurance can look like this, I think, and we have a whole webinar on this. We'll be doing another one, I think, in January or February, and I think the take-home message on this is this is not dental billing. This is a medical procedure done by a dentist. And if you don't know much about this, then we highly, highly encourage you to use a third-party biller to do this, because you might be good at doing all these things on the screen. You probably aren't so good at defending yourself if you get sued, or doing your own taxes, or flying your own plane. You might as well do those things as do medical billing. I mean, I would just as soon prepare all my taxes and go to court on my own as I would to figure out doing medical billing on your own. So good news is there's people that can help you. We have a company, our subsidiary, 4-Pillar Billing. There's other good companies out there that can help you do billing. So, I say a lot, Rich, these people don't know how good they have it, because they started, there weren't companies like this. We had to figure this out on our own. There wasn't home sleep testing, was there? There weren't systems like DS3. There weren't webinars for free on a Tuesday night that you can attend and to help you. So there's a lot of things that are much improved for you as far as helping you do this. And these are decisions you'll have to make. I don't think we need to get into the weeds on that. I think, pulling back out, we started up here, we went down to a little bit more granular. What we have on the screen, Rich, it's as simple and as complicated as those 4 pillars. That's why we preach it. Screening, testing, treating, and billing. That's all there is to this. You've got to do it. You've got to have team members do it, and you got to believe it's your job.
Yeah, again, you can do this under an hour, of your time. You got to be efficient at what you're doing, and you got to have a system. You got to have a way to do this, and you also have to have a really good team, that's committed to it, and they understand this. And all of that stuff. So you did a great job putting that together tonight, Guy. You got to have a plan, though, don't you? You want to make this work.
You have to have a plan. And one thing I think a lot of people ask what we do at DS3. What is it that we do? And we help dentists achieve the level of success that they want to with dental sleep medicine. And if you know where you are and you have a desired goal of where you want to be, we will be happy to meet with you. Just type in consultation or consult, something like that. And one of our member support team experts, I mean, these are people that have years of dental sleep medicine experience, will sit down and look at what you're doing, and we will help you understand what you need to put in place to get where you want to go. Because this desired state out here, this gap analysis we're going to do is different for every office. Some of you want to sell your practices and do 87, how many did you do? 80-something devices in a month. Some people just want to treat their patients. Huh? What's that?
A bunch.
A bunch. Some people just want to treat the patients that are their own patients. There's all in between, and we just need to understand where you are, where you want to go, and what's missing there. And there's no one in the country that can help you understand what's missing better than us, because we've been doing this longer and for more dentists than anybody out there. So take advantage of that. Type in consultation. One of our member support team people will, it's not a big sales push. We'll certainly tell you about our services. You will get tons of value out of the free consultation that we can give you. We have pretty much everything you need at Dental Sleep Solutions, a 360 solution. When we say that, we have partners that provide some services. We provide services ourselves, and we have the knowledge and experience to help you achieve whatever level of dental sleep success is for you. So please take advantage of that. Again, next month, we'll be talking about medical approach to referrals in December on a Tuesday night, I believe it is. Rich, I know you'll be talking about that, so I'm sure we'll work on this presentation together. It's always a really interesting one, and I think worthwhile.
Absolutely it is. You know, it's kind of a different way of marketing as well. We talked about with the letters, you know, when we're writing those letters, we're constantly staying in front of those doctors. Oh, there's a letter from Drake again. Oh, there's another letter from Drake. And the next patient walks in, got sleep apnea and not using their CPAP. Hey, you should go see that guy Drake. You know, he does that. So again, I'm looking forward to that one, Guy. Again, if you're not getting the Dental Sleep Insider, it's free. It's another thing that we do for free. We just throw free stuff out there all the time. And we do it better than anybody else out there. You know, this is an unbelievably practical magazine, digital magazine that is just full of little practical pearls. Guys always doing a video about how to shave this off or cut this or add that, or, you know, doing all these types of things. So, you know, and again, it's one of those things that's free. So, you know, just reach out to us and we'll get you on that list. And
there you go. And here's how you get a hold of us. Again, you're going to get your CE. If you don't see it, look in your junk folder. If you can't find it, then by all means contact us. So, contact us for any questions that you have about dental sleep. That's, I mean, just to be clear, we have a team of a few dozen people that show up for work every day just to help dentists with dental sleep medicine challenges. So I don't know of any other organization that really does that. There's just we should see our big room we have. It's just this room, and that doesn't include a lot of the people that don't even live in around the corporate office. So we have all the resources you need to succeed. Rich, I know the team, our proficient team, and you have been answering these questions. Look at this, man, we're finished on time. I hope the background noise hasn't been too much here in the
no, it's just I can just barely hear it. So
okay,
that's good. You know, the couple of things, Guy, maybe we'll just touch on real quickly here, looking through a lot of these things. You know, one of the things I want to make sure everybody understands is that this whole sleep apnea thing, it's not a perfect system. You can have somebody do a sleep test. You know, when we look at 3 nights of a home sleep test, we typically see an RDI of 5 one night, 12 one night, and 19 another night. You know, so they might not even have sleep apnea one night, but another night they might. That's just the variability of sleep, you know, in our airway. It's not a perfect science, and this is part of the paradigm shift that we always talk about, Guy, with dentists. It's so hard to go from 1/100th of a millimeter to something that we're looking at that doesn't make any sense to us, because one night they don't have sleep apnea and the next night they have severe sleep apnea. You know, that's just the nature of the beast.
It's not the test. Let's be clear on that. The test is picking up the information. It's that you're sleeping differently. You're sleeping on your side. Your nose is clogged up one night. You're tired, more tired. You drank something. All these things affect our airway. That affect how we sleep. And so it's not. We don't sleep the same way every night. And it's one of the challenges. It no doubt is. But that being said, I always say it's kind of the tip of the iceberg. If you show you have an airway problem, then we know you have that, and it can rear its head at any moment, and making the airway better is certainly a good idea. And I said, tell you, I'm a believer. I've been wearing a dental device myself for at least 15 years, and I honestly believe it's one of the best things. I almost feel like just by luck that I got involved in this, that I'm a much healthier person than I would have been had I not found out about this and been treating myself. So, it's challenging for you, Dennis, but it's also, once you get over the fact that it's different, it's easier because it's not exact.
Much easier. It's much easier.
It doesn't always work, and that's okay. And it's kind of nice to know, because when a crown doesn't work, it's a bad day. When a root canal doesn't work and an implant doesn't work, it's a bad day. When a dental device doesn't work or sleep test is marginally better, that's a good day. It's a good day. And once you get over your own selves on this, it really becomes easier. So we are putting together, one thing I'll mention, our in-person two-day courses for 2019. That's almost finalized. We should have that by the next webinar. We're slated to do maybe 15 or 20 two-day hands-on courses, and we'll have those dates. So look at our website. If you're interested in a course, you can still type in course, and I think Rich will yell at me, but we'll give you $200 off on one of the courses. We'll when those dates are published soon. So you can type that in just to secure that, and we'll put you on our list to let you know. They're all over the country, and I think you'll like what you see there. You'll learn a lot. And the symposium's completely different. We had that slide earlier. That's if you want to know more about the symposium, type in symposium. We do put this on, but it's not promotional towards our company at all. It's really, we bring in, what we do is we leverage all of our friends and people we know to get some of the top, I wouldn't say some, I would say the top dental sleep experts come in, and they're one after another. And I personally look forward to it. I learn more there in a day and a half than any other place in the country. So we encourage you to come for that too. So if you want to come to that, just type in symposium if you want more information. Rich, I think all the questions, man, y'all are great. I think the questions are pretty much all answered. Do you see anything on here we didn't get to?
No, I think that looks good. As always, you and Jason do a fantastic job of putting these PowerPoints together. So I appreciate that. Makes my job easy. I just kind of show up with my iced tea, and you let me talk every now and then. And not
too often, but I'll let you talk some. Get a little long-winded with a little delay. I'll blame it on the internet delay here in North Carolina. So, anyway, well, everybody, thank you for taking your time. We appreciate you being on, and we hope to hear you on again in December 11th. December 11th. All right. Well, then I'm going to hit the off button here.
Have a good night, everybody.
Everybody, have a good night.